So for today, our learning objectives is we're going to work to understand the difference between implicit and explicit disability bias. Learn about the prevalence of disability bias among healthcare providers today. Become aware of disability bias embedded in common language and in medical charting notes. And we're going to explore ways to implement access check-ins. And all of this is part of gaining tips on how to practice disability allyship from both the professional as well as personal experiences of healthcare providers and of patients. So how are we going to accomplish our learning objectives today? Well, we're going to do this in a slightly different format and one that we hope is more interactive. First, we're going to start out by just briefly reviewing some of the latest research on disability bias among healthcare providers. Then, we're going to review and explore the ways that ableism and disability bias show up in healthcare interactions and spaces. We'll briefly review some of the strategies based on the research that help increase access to healthcare. And then we are going to turn to two panelists who are joining us today who generously agreed to share some of their own experiences. And we will then open it up to questions from all of you, the audience, for our panelists. So just to start us off, I want to take a brief moment and introduce myself. My name is Heather Evans. I am a white woman. For those with low or no vision, I have brown and gray chin-length hair. I'm wearing a brown polka-dotted top, and I identify as disabled. I have a chronic illness that causes a variety of physical and cognitive impairments, as well as a mental disorder. So in addition to the lived experience that I bring to this work, I also have a PhD in sociology, and I work at the University of Washington here in Seattle as an assistant professor in the Department of Rehabilitation Medicine. I'm currently the director of the UW Disability Studies academic program, and I have the pleasure of serving as the director of research for the Northwest ADA Center. So I share this with you just so that you are aware that this work is very important to me, both personally and professionally. So in our previous webinars, if you were able to join us for webinars 1, 2, and 3, you'll note that we've discussed some of the key barriers to accessing healthcare for people with disabilities. And those barriers include inaccessible healthcare facilities, often inaccessible healthcare equipment, inadequate anticipation of accommodation needs, absence of disability perspectives in decision-making spaces, as well as negative perceptions of and assumptions about people with disabilities. And today's webinar, we're going to focus on this last point, the kind of negative assumptions and negative perceptions and some of the assumptions that we make about people like myself, people with disabilities. And another way of thinking about that constellation of negative perceptions and assumptions is talking about implicit and explicit disability bias. So again, for those who've attended our prior webinars, I'm going to ask you to recall that we've talked about ableism, or the name for discrimination that flows from disability bias. So in short, ableism is simply a form of discrimination that includes an assumption that able-bodiedness or able-mindedness is not only the norm, but the ideal. And that this form of discrimination leads to differential and inequitable treatment based on actual or presumed non-typical functioning. Ableism is pervasive across policies as well as the built environment and is embedded in social attitudes and many practices. Ableism is also very intersectional and rooted in the other isms, such as racism, sexism, ageism. And so we want to just start out by noting that disability bias can be explicit, or that is occur at the conscious level, but that we also carry implicit bias, or bias that occurs at the unconscious level. So, for example, on this slide is an image of an iceberg that we want to use as kind of a metaphor for bias. And if you think of that water line as the line of consciousness, the part of the iceberg above the water line is explicit. We are aware of these attitudes in ourselves. We can report on them in surveys or questionnaires. But like an iceberg, what is below or what is above the surface is just that tip, and that often the largest part of an iceberg is below the surface. And so below that line of consciousness, that is where our implicit biases lie, of which we're largely unaware. But note that even if we're unaware of these implicit biases, they still have an influence on our behaviors and decisions. And these are often measured through indirect measures, such as an implicit association test. So there has been a fair number of research about disability bias, and I'm going to summarize some of that briefly. Note that prior research indicates that disability bias in general is lower among healthcare professionals compared to many other professions, but that it is nonetheless still pervasive. Research also indicates that levels of explicit bias among providers vary across kind of the career life and also across specialties. So, for example, explicit bias tends to lessen over time throughout the educational and clinical process. However, we also see discipline specific differences in explicit bias. For example, PT or physical therapy students have been shown to have less favorable attitudes compared to their counterparts in OT or occupational therapy. However, when we look at implicit bias, research indicates that healthcare students and professionals tend to have similarly high levels of implicit bias as compared to those held by the general population. Implicit bias tends to remain stable throughout the educational and clinical practice and career. So again, this points to provider beliefs that many times we feel like we're not biased in healthcare spaces, but we see that implicit bias remains and is there despite consistent differences in clinical interactions with disabled people. So overall, there is a lot less research on implicit bias in healthcare professionals compared to the research on explicit bias. And one of the reasons for this is that implicit bias is frankly hard to measure. And we currently have things like the DIAT or the Disability Implicit Association Test to measure those things. But that test in itself is an imperfect tool. So, one of the folks who has done some research and studied both implicit and explicit bias is Dr. Heather Feldner, who is here today with us and will be our guest panelist. Dr. Feldner and her colleagues conducted a study with over 25,000 healthcare providers. And I'm just going to briefly kind of summarize that they found that healthcare professionals had relatively neutral, explicit, or again, conscious disability attitudes or bias, with 63.7% of participants reporting no strong preference for disabled or non disabled people. About 30% of respondents reported slightly, moderately, or strongly preferring non disabled people, and only about 3.5% slightly, moderately, or strongly preferred disabled people. When it came to implicit bias, however, results revealed a significant skew, with 3/4 of participants holding strong, moderate, or slight unconscious bias against disabled people and preferring non disabled people. About 11% of participants had no preference, and only about 6% of healthcare professionals slightly, moderately, or strongly preferred disabled people. So, again, understanding that implicit biases are much harder to change given their tendency to be hidden or unconscious, these results make sense. but it also reinforces that we all have work to do to try and reduce implicit disability bias, along with other intersectional biases in healthcare. So now that we have confirmed that disability bias persists even among healthcare professionals, what are some of the consequences of these biases? Well, there are a summary of findings on this slide, but they are next to an image of a smiling white man with Down syndrome holding a handwritten sign saying, "I am ventilator worthy. I want the right to live." We include this image to remind our audience that these debates about healthcare disparities are not simply a thing of the past, and that disability bias continues to be extremely relevant, especially in times when discussions emerge about, for example, needing to ration care. So turning back to the literature, research shows that significant healthcare disparities exist for disabled patients due to a complex interaction of effects, but that most of these disparities result from factors that are not related to a specific health condition. Studies demonstrate that biased or ableist provider beliefs and attitudes, whether explicit or implicit, influence patient encounters, referrals for care, and clinical decision making. And importantly, even the ICF, the International Classification of Functioning for Disability and Health, even the folks at the ICF has determined that provider beliefs and attitudes are a significant environmental factor that has to be addressed in order for us to improve healthcare outcomes for disabled people. By the way, as a side note, I just want to let folks know that we've included citations and references in the notes sections of the PowerPoint slide deck, which again is available to you to download on our webinar website. So if you'd like to review the research articles that we use to compile this summary, you're welcome to do so. So now that we've talked a little bit about the current research, how does disability bias show up in healthcare spaces? Again, we've talked in previous webinars about the small and big ways we might overlook accommodation needs in physical spaces and in policies. But importantly, disability bias also surfaces in the direct interactions between healthcare professionals and patients. So some of the ways that this bias shows up includes when healthcare professionals make assumptions about patients' goals or desires. That is, when they make assumptions about what patients want to look like, what function they want to have, and that their goal is to appear as, quote, normal as possible. Also, when providers equate learning about a particular condition to living with that condition or diagnosis, this creates tensions. That is, for providers who might rely on disability simulation experiences for understanding and insight and mistake that for the kind of deep knowledge that comes from patients who live with these conditions and diagnoses. Also, when providers are in the habit of telling patients what their priorities should be, rather than inquiring or asking what patients' priorities actually are. Healthcare professionals can also perpetuate stereotypes that disabled people have a lower quality of life, for example, than non-disabled individuals. And also, when we treat health conditions as being isolated from patient identities or try to separate a diagnosis or a condition from the holistic experience of the patient themselves. So I'm sure that all of you by now are saying, got it. Disability bias is a problem. What do we do? So again, drawing on research by others, as well as some research that's been done by Dr. Feldner, myself, and other colleagues, we've distilled our findings into some general tips. And so we're going to give you just 5 broad tips for making your healthcare spaces more inclusive. First, Establish standards of care. And by this, we mean establish standards of care for your clinic, your practice, your organization for patients with disabilities. And this includes thinking through questions like, at what points in the scheduling or intake or exam processes are patients prompted to talk about or request their accommodation needs? When is it clinically appropriate to treat a person with disabilities, for example, in a wheelchair versus transferring them to an exam table? How will you schedule and bill for extra time that may be required to accommodate a disabled patient? That is, time that might be associated with using an interpreter, making transfers from wheelchairs to exam equipment, providing aftercare instructors in language that is plain enough for, say, a patient with a cognitive or intellectual disability to be able to understand them. So next, we suggest start and end each visit with what we call an access check-in. That is, begin each visit by asking, do you have any accommodation needs that we should talk about before we begin to make sure that we get the most out of your visit here today? Don't make assumptions about the priorities of disabled patients. Always ask what they want to address or what they want to focus on during that visit. Listen, ask questions, double check for comprehension of what's being discussed, of course, with all your patients, but particularly with patients with disabilities. Third, start noticing and adjusting disability bias in the language you use. That is, avoid language that insinuates that disability is some kind of all consuming, never ending tragedy. That is, avoid language like confined to a wheelchair, bedridden, someone is afflicted with or suffers from a particular condition. In general, try to avoid language that minimizes or diminishes psychosocial disabilities. I know for myself and many of my colleagues, I hear it come out of my mouth to say things like, oh, my schedule is insane this week, or I am so OCD today, or comments like someone needs to take their meds. Keep in mind that when you use language like this, it really does diminish the experience of individuals who might have these diagnoses. And probably most importantly, always focus on using descriptive, neutral language rather than, say, value laden language when you're charting or making medical notes. Rather than say that someone is non compliant, aggressive, disengaged, has poor hygiene, think about and describe that actual behavior, action, or appearance in neutral terms, because these are the kinds of labels that often carry an associated stigma when coupled with disability. We also encourage you to really take a close examination at your institutional practices. And that might be for the organization or for your work group. But ask yourselves if or to what degree disability is represented in your workplace, particularly in your leadership teams. Make sure and include disability in diversity, equity, and inclusion initiatives. Remember, disability simulations only reinforce stereotypical disability experiences. Incorporate disability allyship trainings and opportunities into work activities like this one. Everyone here should take a moment and give yourself a little pat on the back. I'm going to pause for just a moment, and I noticed that we got a question about an example of how to describe a patient with poor hygiene who may have difficulty washing or cleaning themselves. This is a great question. And actually, some of the answers in your question. Rather than jotting down a patient has poor hygiene, you might include a note that says the patient had unwashed hair and noted that they have difficulty washing their hair. That's a little extra information, but it's neutral and it describes what's going on there, rather than just saying someone has poor hygiene, which can often be associated with things like laziness or lack of engagement. Some people actually can interpret that as to be a lack of respect in seeing providers. And then our fifth tip is just a reminder, do a walk or a roll through, depending on how you stroll, all the spaces in which your patients will be, right? Make sure that you've planned ahead to provide access for all types of bodies and their assistive devices or companions. And so that means questions like, are there seats that will work for people of all body types and sizes? Is the waiting room arranged in a way that will accommodate power wheelchairs? Is there somewhere for people who use canes, for example, who use canes to position them while they check in or fill out paperwork? Will your elevators accommodate power wheelchairs? Is there a parking space that's available for a vehicle that uses a ramp or a lift to one side? Is there a relief area for service animals when they arrive to your clinic? So this was just a quick overview of what the research has to tell us. Next, we are going to turn to the invaluable perspectives of a provider and a patient to talk about their experiences and insights. And we are especially thrilled to have these panelists who both identify as having some different ways of functioning. And we want to highlight the often overlooked fact that many of us who work in research or in healthcare professions are also patients with disabilities. So we are, again, very happy to have joining us today Dr. Heather Feldner from the University of Washington. Dr. Heather Feldner is an assistant professor in rehabilitation medicine, focusing on physical therapy. She is a core faculty member of the Disability Studies program, an affiliate faculty for the Center for Technology and Disability. Dr. Feldner is the director of the Impact Collaboratory and the associate director of CREATE. We are also very fortunate to have with us Justice Chukwu. Justice is a technical assistant specialist at the Northwest ADA Center. So I'm going to ask Justice and Heather a handful of questions, and then we are going to open it up to the audience. So again, please prepare and send your questions through the Q&A function for our panelists. For this portion, I'm actually going to stop sharing my screen so that those of you who can see will have a better view of our panelists as they respond to our questions. Fantastic. Thank you. So, Justice, I would like to start with you. First, I'm going to ask you, feel free to tell us a little bit about yourself. And then I'm wondering if you can walk us through or tell us how you prepare for an appointment with a doctor or provider that you're going to be meeting for the first time.
Very much, Heather. Can you hear me?
I can.
Thank you. And thank you for the formal introduction. Personally, I would like to be casual today because I'm having a chat with my fellow ally within the disability community. I am Justice Chukwu. You can call me the Blind Justice Chukwu. I am a Black, smiling, handsome, blind man. Yes, I'm very happy to call myself handsome, and because that is who I am. And I want to use this opportunity to tell you that you all are beautiful. and handsome in your own ways. And it is because of you that we are having this conversation, because of me, because of all of us. So I'm so happy and thrilled to be speaking with you all today. Speaking of how I prepared for the first medical visit or appointment, I will speak from my perspective, not only as a blind person, but also as an immigrant in the United States of America. So when I moved to Portland a few years ago after my education, I needed to sign up for health insurance and also medical appointments. So what I did first was to do my research. And doing this research also entailed reaching out to fellow people with disabilities who are already living in Portland, especially blind persons, and to inquire about the best, services, or where I could get the best services as a blind person. So they gave me a list of options, and they told me some of their experiences with those places. So the next thing I did was to put a call across those facilities, already with an informed questions that I would love to ask them. And I asked them some questions as to the location of their facilities in order for me to understand the accessibility and the distance. So I also inquired about some reasonable accommodations and time, and how to fill my paperwork, because as a blind person, I may need assistance doing that. Then the next thing I did was to finalize on one facility, one medical provider, so to speak, and I scheduled my appointment. While scheduling my appointment, I made sure to schedule the appointment not to clash with my work, and also considering the distance, considering the time, because I am not an early morning person. So I needed to make sure that the appointment was scheduled in the afternoon. And so before the appointment, the next thing I did was to gather some relevant information for myself. What kind of visit did I want to have with this provider? First, since it's the first visit, I would love to have a general conversation about my medical history and how the insurance works with respect to co-pays and stuff like that. So these are some of the questions that I got myself prepared for. Then after which I had to plan for my transportation. So planning transportation for not just a blind person, but an immigrant here is very technical and tricky. So I had to reach out to friends to help me to plan the transportation and understand the time, because I use a paratransit system, which sometimes I needed to plan the transportation 30 minutes before the actual appointment time. Then even while I was having the appointment with the medical provider, I had to request some accommodations, like making sure that that the information was properly described to me, whatever conversation I was having. Sometimes I understand that some medical providers may not even understand that being blind entails, working with a blind patient entails being more descriptive, and demonstrative. I understand sometimes some medical providers wouldn't know how to communicate with a blind person. They may need to tap the blind person or hold the hand of the blind person to describe what they are saying. So sometimes they would like to ask for permission in order to do that. And for me, I would always grant them that permission. Then, but before then, I was also I planned to go with a companion, somebody that would lead me, because then I hadn't so much had orientation and mobility training on how to navigate the city. So I went with a companion. So, and it's also important to take notes while the while you're having a conversation with the medical provider. This also would require extra time. So Heather was mentioning extra time, not just for people on wheelchair or any other type of disability, but also blind patients may also need extra time because they would love to take notes of whatever conversation they are having with the provider. So, so these are some of the things or steps I took when preparing for my first medical appointment, and it was very productive at the end of the day.
This is Heather speaking. Thank you so much, Justice. That was so informative, and I'm just reflecting on your level of education and how much you know to do all of that research beforehand. I really appreciate it. I'm going to turn now to Dr. Feldner, and I'm going to ask you also, I'm going to invite you to tell us a little bit about yourself. And then I'm wondering, since I know that you work primarily with children, whether or not you've ever encountered, say, tensions between what a parent might wish or hope for their child versus the child patient and what they want or need, or maybe even tensions between what you think would be best or most therapeutic for your patient versus what a parent wants to happen.
Yeah, absolutely. Can everyone hear me okay?
I can.
Okay, great. Well, thank you for having me. My name is Heather as well, and in spaces where Heather Evans and I are present together, we typically will refer to each other by our last names as Evans or Feldner. So please feel free to do the same for anyone who might be asking questions. Um, so I am a cisgendered white woman. My pronouns are she and her. Um, I have long gray and brown hair. I'm wearing bright blue glasses and speak with a Midwestern US accent. And I am also disabled. I'm hard of hearing, and I use assistive technology to support my disability, and really only started identifying as part of the disability community a few years ago, and am really proud to be a part of that community. And I am also, in addition to my own experiences, I am also the parent of, as well as the daughter of, family members with disabilities that are different than mine. And my clinical background is in physical therapy, particularly pediatric physical therapy. And my doctoral work was also in disability studies. And so it's kind of with that blend of clinical and academic and more recently lived experience that really shapes and limits the perspectives that I bring to these topics. And with that introduction, I will dive into your question, Evans, which is a great one. And I think there are definitely always tensions between kids and their parents, regardless of whether they're coming to see a physical therapist or other medical provider or not. But I think for me, some of the big ones that have stood out over time in my clinical experience, number one was comfort with technology. To many kids, technology, whether that be related to mobility or related to sensory need or related to communication, or just for fun, really, Technology is embraced by, I would say, a vast majority of the kids that I worked with clinically. And they wanted to learn how to use it, how to incorporate it into their lives, and they really saw the value in different forms of technology providing key access and social participation opportunities. And many parents were hesitant at first because this was a very tangible signifier of difference for their children. And so I think that, you know, there's a lot of complexity and tension kind of within that. I had also seen a lot in my clinical practice, different perspectives related to goals and activities. And for me, as a physical therapist, this was largely around physical activity and what a child was excited about doing, and how they were excited to use the capabilities that they had versus what a parent was expecting. And I think the biggest example of that in PT for sure is this tension between a desire to walk or a view of walking seen as the kind of pinnacle of mobility, as the ultimate mobility goal. When in reality, we all use a lot of different forms of mobility to get around. Sometimes we walk, sometimes we roll, sometimes we sit in an airplane and fly. And again, I think there was this tension because there was this perception of mobility technology, say a wheelchair, for example, as a failure or as a last resort, rather than what I think of it really is as a key means of access and a key means of participation in a world that hasn't really been built for people who move around in different ways. And so, you know, this idea of, you know, walking being the be all end all, and you know, the kids kind of feeling bad if they weren't accomplishing goals related to that. That was a huge source of tension. And you know, of course, we needed to meet parents where they were at in terms of their processing. And no wonder there was this perception, because as you mentioned in the talk, you know, we've all kind of grown up in and been socialized in an ableist society that really values certain ways of being in the world more than others. And so, you know, of course there was going to be that tension and that grief even. And so it was really interesting to kind of have conversations that where you were simultaneously trying to meet a parent and child where they were at from different perspectives, but then also interject your own professional, you know, opinion in terms of, you know, we want mobility to be we are mobile for mobility's sake, right? For fun and enjoyment, but it's also a means to an end of participating and engaging and interacting in the world around us. And so how can we do that most efficiently so that a child is not expending all of their energy just trying to get where they want to go? And so that, I think, is probably the biggest example that I can share from my own practice.
Wow, thank you so much. That is really that makes me reflect on so many things. I really appreciate it. I'm going to jump right into some of the great questions that have been submitted here. So, Justice, I am coming back to you, and one of our participants says, "Are there any laptop type or other type of products that translate medical information for a patient to Braille or for a sight impaired patient?" Parenthesis, yes, Justice, you are very handsome. And so I'm wondering if you can share with us, you mentioned taking notes, etc. What is the best way for you to get access to medical information or written information?
Thank you very much for the compliment. Yeah, I may not give you like an exhaustive answer to this question, but generally we have some screen readers, for example, Jules, that you can install in any computer. And as long as the computer can be connected to an internet, you can have access to your medical information online. So for example, Kaiser would have kp.org. From there, you can access your medical information and maybe after visit and stuff like that. There may be some more sophisticated technologies that can help in doing some more advanced things, or for persons with vision loss. But that may be something that we can do some more research to provide answers for. Then we still have, you can use a Braille. It's either use, we have, what is it called again? We have Braille display. It's very portable that you can use. Either you type using the Braille, or if you have your phone and you can type, for those who are partially sighted, they can use their phone and type and send and, transfer their notes to their Braille display. So you have a lot of flexible ways to still take your notes and store your information.
Well, thank you very much. That is really helpful. Dr. Feldner, I'm going to turn to you. And I'm going to ask you to talk a little bit about disability simulations. We've got a couple questions that have come in, and I am just going to let you take it from there.
Yeah, this is Feldner speaking. Absolutely. This is, I think, one of the kind of critical points of tension within healthcare and medical training and education. And so it's a sticky topic for sure. And I do want to kind of start off by distinguishing, healthcare simulations are common, right? Especially in nursing or medical education, where these involve like smart mannequins that breathe and bleed and have medical crises, and emergent health as they give birth, right? Like there's really cool technology out there to facilitate learning. And that is not the kind of simulation that we are talking about here. Where it tends to go awry, rather, is in those experiences where it's like along the lines of wheelchair for a day. Go out into the community in your hospital grade wheelchair and try and navigate the city and to see how hard it is, right? These are experiences that are designed to encourage empathy. They are designed to provide like a little slice of that. But because, what happens when, as a non-wheelchair user, what happens when I get out of the wheelchair at the end of the day? Oh man, that was hard. Life must suck with a disability if I need to use a wheelchair full time. And so that's where that reinforcement of stereotypes tends to come in. It also tends to reduce the lived experience of disability into this like very minute piece of daily life that may very well be hard, but I would rather hear it from the perspective of the person that lives that every single day, and that's their embodiment, rather than trying to think that rather than claiming that I can possibly understand what it's like to live with a particular disability if I've experienced it for a day or a moment. And so those are the things where I think, although well-intentioned, we really need to take a closer look at as a healthcare community, because those experiences, as we have heard from many people in the disability community, are reductionist, don't serve, actually create increased feelings of pity or things like that. There are alternatives, right? So some of the things that we've kind of seen instead is, doing an accessibility audit. So actually teaming up with somebody with lived experience and hanging out with them for the day and letting them kind of say, okay, here, this is a really accessible entrance for me, and here's why. Whereas someone else might say, for me, if I need to get into this classroom, I have to go and sit at the front of the room every single time. There's no opportunity for me to go in a different space if I want to, or what if I'm late, then everyone's, seeing me as I come in, and I have to sit right next to the professor, which is never comfortable, right? So those types of accessibility audits where you're actually kind of tagging along and learning from that person as an expert is a fantastic alternative, right? We in our program, we have really been careful about paying people to come in and give guest lectures as an alternative to, trying to reproduce something ourselves. And this is a transition, right? Like this takes a lot of thinking about, I think, very deeply. It's certainly something that I experienced when I was a student in physical therapy school. We absolutely did these types of simulations. They're still done today in a lot of programs. I'm happy to say that we have eliminated them from our program here at UW. And in fact, when I was first teaching, I would include them myself, right? This was before I went back and did my PhD in disability studies. And so I feel pretty strongly about them alongside a lot of members of the disability community because I've sat with that material, or I've sat with that concept, and I've sat with that, why that could be seen as really not representative of a person's lived experience. And so I think that, now I see, like, I just have a different perspective now. And I think that's important to recognize too, that people in the healthcare community probably have a very wide-ranging perspective on this issue in particular. And that's okay, but I think we need to engage in that dialogue and really listen to our allies and our leaders in the disability community who are saying this isn't the best way to go about this. There are other really impactful ways to learn about the disability experience.
Yeah, this is Heather. I thank you so much for that. And just as a shameless plug, I mentioned that we'd put some citations and references in our PowerPoint, and the last slide of the PowerPoint, in really tiny font, we have a list of references and resources, and one of them is an article that Feldner and I published together. And I'm just thinking of that example that someone told us about their endocrinologist, someone with type 1 diabetes who had the endocrinologist who told them, oh yeah, I wore an insulin pump for a day. I know all about it. And so, again, and reinforcing that idea of when we talk about language, when we talk about ableism, recognizing that we have all grown up in this socialization, in this soup. We've all internalized a lot of ableism. And so with this webinar, with this information, with all the information at the Northwest ADA Center, none of this is intended to shame or blame anybody for doing anything quote unquote wrong. Instead, it's to offer better alternatives for creating more access. So I really appreciate your response. Justice, I want to turn back to you. And I want to ask if there are any examples that you have that you would feel comfortable sharing in a healthcare space where either you felt like someone didn't anticipate well enough what you would need, or an experience that made you maybe decide to go and see a different provider the next time. I'll put it that way.
Well, okay. That's a very great question, and thanks for asking. Of course, I have the right to change my medical provider. And my rights, I always love to exercise this right when I think I'm not properly served. And there are some factors that would determine, or I use to assess, the quality of service, medical service that I receive from a doctor. First is, not in order of sequence, but sometimes I would look at the physical accessibility of the facility and the staff of the facility and how receptive and respectful they are to me, and how they respect my autonomy, and how they respect my decisions. So these are some of the factors. Sometimes, again, I look at how they receive me. Sometimes some staff, maybe I would understand if maybe I'm having an appointment in the evening. Some of them might be tired and may not be putting some, positive vibes and, good energy, when trying to listen or assist me. So in that case, I would spare them, but not when, such attitude, keeps displaying over time. So some other factors that really make me to switch is when I discover that the medical facilities are not willing to provide me with accessible information, not willing to ask me what type of information or how best, can I receive information. For example, if they just offer me a paperwork without asking me, or even when I try to communicate that, hey, I need this paperwork to be electronic, then I have also had some experience with my support person who came to pick me. He was the one who dropped me off, but he is Black. And when he was coming to pick me, he encountered some sort of subtle racism. So he explained to the security guard that, hey, I am here to pick a blind person who is my friend. But the reception, the attitude he received from the security guard wasn't that respectful. They were looking at him like someone who was actually missing road, or who wasn't supposed to be there. And he wasn't comfortable with that. It took him some grace just because of me to be patient. And when he finally met me, before meeting me, he already met the nurse who he handed me over to. And when the nurse came to attend to him, the security guards rushed to the nurse and asked him if he was safe. So this is a support person who came to assist me. So why I'm sharing this story is that as we are talking about this disability allyship, it's also important to look at our support persons and what they encounter, the difficulty, the challenges that they face when trying to help us. Sometimes they may not even share those things because it might be very heartbreaking to us and very disappointing. So I felt bad at the end of the visit. I wanted to approach the security persons, and he calmed me and told me not to. So the point I'm trying to make here is that we should also try to support our support persons. As much as we are being supported, we also need to support them. Try to ask them, if they would like to share their experiences while trying to help us. Then I think I've also mentioned, like if, for example, I am in the facility, I don't have a support person, and the staff of the facility are not willing to guide me properly. For example, if I come to a facility, I've been to a facility where they were describing the office to me instead of them to lead me to the office. They'll be pointing, hey, you take this left, you take the other left, then you walk straight. I was like, okay. And there will be an elevator by the left, by the right corner, then you get to the elevator, then you press the 3rd floor. I was like, wait a minute. You saw me with a white cane. You know that I am blind, and you are busy directing me. I mean, even a sighted person may still find it difficult. So those kind of services or attitude or behaviors would really, really turn me off, and I wouldn't like to deal with that for the second time.
Yeah. Justice, thank you so much for that example. And I so appreciate you again bringing up a theme that Feldner and I talk a lot about, which is how intersectional access is. And so I really appreciate you bringing that to our awareness. I am somewhat brokenhearted that we are already at time. There are a number of questions submitted that were fantastic. A number of folks asked about examples of more neutral language in charting notes. I believe that Dr. Feldner has some other resources that I may ask her to share on our website. For those of you who have to go right at 1 o'clock, I just want to thank you so much for being with us today. Again, please see our website. We'll have this recording. You'll have the PowerPoint slides, and I'll work to get a couple of additional resources up there. And then most of all, thank you so much, Feldner and Justice, for sharing your expertise, your insight, and your experiences with us today. All right.